Hello and good evening, you all. I hope you can hear me well. And hi, Dr.
Hi.
Alejandra. I'm
Hi, good evening.
glad that you can hear me too. And please
Yes,
just let me
perfectly.
know in the chat section if you can hear me properly as well. I will definitely appreciate that to make sure that all is okay. And fantastic. Thank you for confirming this. Well, some of you perhaps already been here at 6 p.m. UK time, so you have stayed tuned because we just finished like half an hour before. So happy to have you here. And just to quickly remind you that this whole event, Stronger Together event, actually has been brought to you simply because we definitely want to share the knowledge from the top experts in the field, and we want to make sure that you are able to ask your questions, find out more on many different IVF aspects. And as you cannot do the treatments right now or cannot start or continue, we just want to definitely make sure that you are still able to find out as much as possible and get prepared for those treatments as soon as they will be possible again. And of course, Stronger Together, we are doing for when it comes to IVF webinars or online patient meetings. And I am happy to see some familiar names already. And also, just let me shortly remind you that this is possible with the help of our partners that are Donor Conception Network, National Fertility Society, Fertility Clinics Abroad, EggDonationFriends.com, and also WhereIVF.com. And today with us, we have another very special guest, and this is Dr. Alejandra Aguilar Crespo from Juana Crespo, which is located in Valencia, Spain. Hello to Valencia in such case. Hi, how are
Hi.
you?
Hi, good evening, everyone. So,
Happy to have you
first,
here. And just wanted to simply add that Dr. Alejandra will talk today about IVF and miscarriages. Is PGT-A a cure? And we will start with the most common questions that are asked by the patients. But then, right after, she will answer your questions, so you can type them all in the chat section, and she will answer them one by one. And of course, remember, it is being recorded, so you will have a chance to rewatch it on our website. And the links to our website, My IVF Answers, are in the chat section already. All right, I believe we can go ahead with it. Dr. Alejandra, are you ready?
okay, yes, thank you. Okay, so hi, good evening, everyone. First, I want to thank the organization because it's a pleasure for me to participate in this webinar. Okay, so as Caroline told before, today's topic is IVF and miscarriage. Okay, and if the preimplantation genetic testing is we have to perform in every time. Okay, well, to begin with, I would like to talk about the prevalence and incidence about miscarriage, okay, in general population. Okay, so the risk of miscarriage, of a first miscarriage in general population is around 15%, okay, whereas after an IVF treatment is around 20%, okay. Why? Why is slightly higher in after an IVF treatment? Because usually people going through an IVF are older, and also they have several pathologies, several reproductive pathologies, which I will explain later. Okay, so that is why this percentage is slightly increased. Okay, but it's practically the same, so you don't have to be afraid of that. Okay. There are several causes of miscarriage. Okay, the most important one and the most frequent one is genetic abnormalities of the embryo. Okay, at least 60% of first trimester miscarriage are due to chromosomal abnormalities of the embryo. Okay, what is that? In normal conditions, people have 46 chromosomes. Okay, and when there is an extra chromosome or one is missing, okay, the embryo sometimes they could not develop. Okay, depending the location of the aberration, we can have some pathologies, okay, which is, for example, if there is an extra chromosome 21, this will lead to a Down syndrome, okay, but usually after an embryo which is abnormal, we will have a miscarriage or an implantation failure, okay. So this is the most important, the most frequent cause of miscarriage, okay. And this is very important because the older the woman, the greater are the number of chromosomal abnormalities, and therefore the higher is the risk of miscarriage, okay. Usually after a woman older than 40 years old, she has a 40% of risk of having abnormal embryos in her IVF treatment, okay. And this is very important. How do we know that we have a normal or abnormal embryo? First thing is that we can perform the PGT-A, which is, I will talk later, okay? Or we can do an embryo hysteroscopy, okay? In our clinic, we always want to know the diagnosis. We always want to know why a woman has miscarried, okay? So after a first miscarriage, we perform an embryo hysteroscopy, which is a biopsy of the embryo. Go through an hysteroscope. We take a sample of the embryo and we analyze the chromosomes, and then we will know if the embryo has the correct number of chromosomes, okay, to try to know if the woman has miscarried because of the embryo or because of other causes, which I will talk right now, okay. Then the second most frequent cause of miscarriage are thrombophilia, okay, and the most known is the antiphospholipid syndrome, okay. This is a condition that can cause clotting problems, okay. These clots can go through the placenta, and this can cause the death of the embryo, okay. And then the third cause is problems with the uterus, and anatomic or uterine problems, and this is earning a lot of importance now. And in our clinic, we focus a lot on the uterus, and this is very important because, for example, we perform a study in which we took 100 embryo hysteroscopies, okay, and we found that 65% of those embryo hysteroscopy of those embryos were abnormal, okay, and the rest of them, 25% of the normal embryo, all of them. They had a uterine problem, okay, such as adenomyosis, which is a very important condition, okay. Uterine could be uterine fibroids, uterine adhesions, polyps, or Mullerian malformations such as septate uterus, T-shaped uterus. Well, a lot of pathology. So it's very important to know the diagnosis. It's very important after a first miscarriage to know why a woman has miscarriage. If it's because of the embryo, because of the uterus, or whatever, okay? And then there are also less frequent pathologies which are a little bit controversial. Some authors say that this can cause miscarriage, and some of them they don't think that. So, which are, for example, the cervical insufficiency, okay? But it's probably led to a second trimester miscarriage and not a first trimester, okay? And then finally, it's the high sperm DNA fragmentation, okay? And environmental factors, which are very controversial, but some authors say that they could provoke a miscarriage, okay? And then just say that we have several tools to try to prevent or try to decrease the risk of miscarriage, which I will talk you later. I think it's more or less a big summary of miscarriage.
Perfect. Thank you so much.
You're welcome.
Now, of course, let's go to the most common questions from the patients. So
yeah.
we can tackle them first, and we will go with the questions from our patients. So the first one is, what's the APGS, how it's performed, and what techniques is used to do the diagnostics?
Okay, so the PGT-A is the Preimplantation Genetic Testing, okay, and A is for aneuploidies, okay. This is a preimplantational, what does mean? That we do a biopsy of the embryo. We take a sample of the embryo. Okay, the embryo should be on day 5. Okay, the lab needs to guarantee a proper culture to blastocyst stage, which is in day 5 or 6. Okay, and we took 5 to 10 cells of the trophoectoderm. The trophoectoderm is the external part of the embryo, which will be the placenta. Okay, we cannot biopsy the inner cell mass, which is gonna be the embryo, the fetus, because it dies, the embryo. Okay, so we take a sample of that and then we analyze the embryo. It's frozen, and then we analyze these cells. The technique that we analyze these cells is called next generation sequencing, okay, which is a complicated genetic test, okay, but this is the technique that we do the karyotype of the embryo, and we can rule out aneuploid embryos. Okay, this technique says if the embryo is normal, is abnormal, or is a mosaic. Okay, which I don't know if people know what is a mosaic, but a mosaic embryo is an embryo that has normal and abnormal cells together. Okay.
Mm-hmm. Perfect. Thank you so much for that as well, for the explanation for this question. Now let's go to the next one. Are people who undergo an assisted reproduction technology more likely to have a miscarriage than those who conceive spontaneously?
Okay, so as I told you before, the risk of a miscarriage in general population, I mean, after a spontaneous conception, is 15%. Okay, regarding the age, regarding the risk, okay, is 15%, and after an assisted reproductive technique is around 20%. Okay, here we have to differentiate. The recurrent pregnancy loss, okay, which is a different entity, because its management and treatment is different. Okay, people who has more than 3 miscarriages in a cycle, or even in spontaneous conception, they are more likely to have another miscarriage. Okay, but in general population, no. And after an IVF treatment, the risk is around 20%. Okay, because as I told you before, people going through an IVF, usually they are older than people who conceive spontaneously. Okay, and they have several reproductive pathologies, such as adenomyosis, such as fibroids, such as hydrosalpinx, and that can lead to a miscarriage. Okay, so it depends, but the risk is slightly increased, but not a lot.
Mm-hmm. Fantastic. Thank you for your opinion and your comment on this question as well. And now, are people who undergo an IVF with own eggs more likely to have a miscarriage than those who use donor oocytes?
Okay, so this is depending of the age of the women. Okay, for example, when we use donor eggs, these oocytes they come from donors. It means that by definition, a donor has to be young. Okay, between 18 and 35 years old. Okay, why? Because that we guarantee that the risk of chromosomal abnormality is very, very low. So the risk of miscarriage, as I told you before, the most frequent cause of miscarriage is genetic abnormalities of the embryos. If we find an oocyte with the risk is very, very low, probably this risk of miscarriage will be decreased. Okay, but in a woman being 32, less than 35 years old, probably the risk will be the same as using a donor. Okay, in general terms. Okay, here we need to personalize each treatment and to personalize each patient, because in general terms, depending on the age, after the age of 40 years old, the risk of miscarriage increase because the risk of chromosomal abnormalities in the embryo is very, very high.
Mm-hmm. Okay,
Yeah.
thank you so much. And if I may ask, at your clinic, is there like I would say age limit for patients that would like to go for own eggs, or you
There
just do it?
isn't. There is no. I mean, there is no limit because
Mm-hmm.
there is no limit because if a patient, if she wants to try with her lungs, depending on the age, of course. For example, like if a woman is asking for a treatment with hormones at 45 years old, we'll say, okay, we will say, okay, it's very difficult, but if you want to try, we will help you, okay? And in that case, we will perform the PGT, okay? But we have several pregnancies with people being pregnant with her own eggs at the age of out of 42, 43, even 44, okay? But it's depending on the situation, it depending on each patient, because sometimes they have some of the problems that they can even have any chance of get pregnant. So we don't have any criteria. It's depending on each patient and depending on the situation we decide.
Fantastic. Thank you for clarifying that one as well. Okay, and let me go to the next one. If I have a miscarriage after an IVF, do I have increased chances of having a second one?
Okay, so depending on the number of miscarriages, that's sure. As I told you, if you have more than 2 miscarriages, the risk of having another one is high. And the older the woman, the higher the risk of miscarriage. Okay, but I must reassure you that women who had a first miscarriage after her first cycle, they have around 40-45% increased odds of live birth after in the subsequent cycles compared to women who had no pregnancy. Okay, so I know that if at first miscarriage they increase the anxiety, people want to cancel, or it's very, very emotional for the patient, but we must reassure them that it's better that a complete negative test. Okay, because the statistics say that, okay, we will try to improve that. We will try to know why she has miscarried, if it's because of the embryo, because of the uterus, because of wherever. So no, the answer is no. She doesn't have increased chance of having a second one, depending also of the age of the woman, depending on the embryos, depending on a lot of things. But I don't think that is she has more chances of having a miscarriage, another one.
Okay, thank you so much again for this answer. And is PGT-A PGS recommended in all cases?
Well, no, of course, this is no recommended. Okay, and this I want to be very, very clear. Okay, it's in our clinic we personalize each case. Okay, it's very, very, very important to know that the PGT, okay, is a very effective tool, but for those who will benefit from it. Okay, and who will benefit from it? We have 2 types of patients. Okay, the low risk patients and high risk patients. Low risk patients is high risk patient is, for example, a couple who has a chromosomal abnormality in their karyotype, okay, or they have X-linked disease, or they have any monogenic disease, okay. This is mandatory to perform the PGT. Okay, people who had a chromosomic problem, we have to perform the PGT to try to increase the pregnancy rates and decrease the miscarriage rate, okay, without any doubt. But there, on the other hand, we have the high risk, low risk patients, okay, which are, for example, recurrent pregnancy loss, implantation failure, older women, or severe male factor, okay. In that cases, it's controversial, the use of PGT-A, okay, depends of each case. Why? We have pros and cons, okay. This is in our clinic. We think that, okay, the pros, it's a well-known fact that the PGT decreases the risk of miscarriage and improves implantation rates in different people, okay. Imagine that we have a woman, an older woman with a polycystic ovaries, okay? She will have a lot of embryos, okay? But we know that because of her age, she will have a lot of abnormal embryos. So in that case, we can perform the PGT. Why? Simply to decrease the time or the treatments until a pregnancy, okay? If we have 10 embryos, and then we know that probably because of her age, we expect to have 3 or 4 normal embryos, we can do the PGT to try to decrease the time until her pregnancy, okay? And also to decrease the twin pregnancy rate, to decrease the multiple pregnancy, because in that case, probably we will transfer more than 1 embryo to get 1 pregnancy, okay? This is when it's better to do the PGT. But on the other hand, it's important to say that the PGT is still a developing technique, okay? We need to have a very good laboratory, okay? Because the lab needs to guarantee a good culture to blastocysts, needs to guarantee an efficient vitrification technique, and also needs to guarantee that the embryo will not be harmed after the biopsy. Okay, so indefinitely we need to rely on the embryologist's skills. Okay, and sometimes some clinics, they don't have these conditions. Okay, then another thing is that sometimes we don't have even embryos to be biopsied. For example, in people who have a low ovarian reserve, sometimes they don't have even embryos to be biopsied, and this can increase their anxiety and also increase the cancellation rates. Okay, also for example, women who had a very poor quality, okay, such as women who have endometriosis. Okay, we know that the endometriosis affects the oocyte and affects the embryos. Okay, the embryos will be in a very, very poor quality. So in that case, sometimes the embryo could not even reach day 5. So we cannot expect to those women to produce a lot of embryos to be biopsied, because it won't be the case. So in that case, in our clinic, we need to think, okay, what do we want? We want an opportunity or we want a security, okay? Sometimes these patients, a low ovarian reserve or people with endometriosis, a transfer on day 3 they will benefit from a biopsy, because if we do a biopsy after in an embryo coming from an endometriosis, an older woman, probably will kill the embryo, even if it's an euploid embryo. So sometimes we cannot assure them that after the biopsy the embryo will survive. So we need to guarantee, we need to give them an opportunity to a transfer, and sometimes this transfer should be on a day 3 embryo or even a blastocyst without any biopsy. Okay, and also the last thing is that to do the biopsy, okay, we need to take a sample of 5 to 10 cells, okay, and these cells, they prevent from the trophectoderm, and sometimes we find false positive. Okay, it means that the cells that comes from the trophectoderm doesn't correlate very well with the inner cell mass, and sometimes if the lab inform us that this is an abnormal embryo, when it is not the true case, and this is called false positive. And this is the thing with the mosaics. Okay, a mosaic embryo is an embryo which has normal cells and abnormal cells. Okay, it has been demonstrated that at least 20% of the embryos issued from a cycle, okay, they are mosaics. And these mosaics, they have slightly less implantation rate and clinical pregnancy rate, only slightly less than an euploid embryo. Okay, what does it mean? That these embryos can lead to a healthy babies. Okay, and in that case, if we don't perform any PGT, those embryos would implant. But if we do the PGT, this embryo in some clinics they will be ruled out. Okay, depending also of the level of mosaic. If it's a low risk mosaic of high risk mosaic, depending on the location of the abnormality, the percentage of chromosome affected. Well, it depends, but this is now we are facing this type of disadvantage, which are the mosaic embryos. So it's very good. The PGT-A is a very good diagnosis tool, but we need to focus on, we need to personalize treatment, and we need to select very, very well this patient. Okay?
Perfect. Thank you so much
Okay.
for all the details. So to many patients. So now let me go to the next one. So would you recommend PGT-A in egg donation programs?
From my point of view, no, because usually they are low risk patients. Okay, I mean every donor is checked for monogenic disease, is checked for a karyotype. So probably the people who is going through an egg donation, they have the risk of miscarriage are similar to the general population. There is no higher risk of miscarriage. Also, just for genetic testing, okay, but we need to focus on the other causes of miscarriage in that population. But no, definitely I will not recommend. If the patient asks because she has a lot of previous donations with miscarriage, we can offer, of course, but not in the entrance, not in the first consultation. I don't think it will be beneficial for the patient.
Thank you for clarifying that for us as well. And now let me go straight to the next question. Is PGT-A biopsy safe for embryos?
Okay, this is very important because this is the technique that is it depends on the biologist's skills. Okay, so it's very important that the biologist is very, very well trained. Okay, because yes, the biopsy is I mean the name is the biopsy is taking cells, okay, and this produces a rupture of the embryo. Okay, I mean it's made by some techniques, like I don't know how to explain, but it's like a rupture of the embryo, but usually we don't harm the embryo, okay? And it's a very, very safe technique, but is an invasive technique. Now now we are the genetic and the future is a non-invasive preimplantation testing, which is the metabolomic and genomic, okay? But no, if we have a very good lab, very well trained lab, I think that 90% of those embryos will survive after the biopsy. But it's very important the biologist skills. Okay, you don't have to be aware of that, but it's still an invasive technique.
Thank you again. Thank you again for that answer. And now let me go straight to the next one. Is PGT-A done on fresh or frozen cycle? Which is better?
Okay, usually it's done on a fresh cycle. Okay, it can be done in both cycles. Okay, from our point of view, it's better to do on a fresh cycle. Why? Because when you freeze an embryo and then you warm the embryo and then to do the biopsy and then refreeze the embryo, I mean the embryo loses potential. Okay, so it's better if we don't touch too much the embryo. Okay, so it's better if we don't in a fresh cycle, because it means that after fertilization we culture the embryo into blastocysts, then we do the biopsy and we freeze the embryo. If it was in a frozen cycle, means the embryo reach day 5, we freeze the embryo, we defrost the embryo, and then we do the biopsy. So that's not very, very, very healthy for the embryo. But sometimes, for example, if we have patient, if you have patient and they have embryos in other clinics and they want to transfer, sometimes it's very mandatory to do the biopsy, because we we find any chromosomal abnormality or she had previous miscarriage, I don't know, and we have to do the biopsy, we can do. But we even prefer to do another cycle and do the PGT-A in a fresh cycle than use the frozen ones, because the embryo lose potential and lose implantation potential. Yeah.
Okay, perfect. Thank you so much again for explaining this to us as well. And now the next question: can heparin and or low dose of aspirin treatment prevent?
Yes, prevent miscarriage. Okay, a lot of patients also after a first miscarriage, they want us to give them heparin or aspirin. Okay, and we need to explain them that in absence of thrombophilia, in absence of clotting problems, okay, it has not been demonstrated that this treatment improves the outcome. Okay, so no society, no reproductive society recommends this treatment empirically. Okay, yes, it's true that in our clinic, almost 90% of our patients, they have adenomyosis, and they have the implantation rate are decreased compared to general population. Okay, and 90% of our patients, we do an hysteroscopy. Okay, and in that cases we use heparin, but only after the transfer until the pregnancy test. Okay, because it's very important, and if we use the heparin, okay, the heparin is an anticoagulant, okay, it can provoke miscarriage, okay, and unfortunately we have had cases that they use heparin without our prescription, and have take heparin or low dose aspirin, and they have miscarriage because they started bleeding. Okay, so it's very important that if it's not recommended, if you don't have any thrombophilia, you don't have to take that medication. Okay, yes, only we here in our clinic, if the patient has not any thrombotic problem, any thrombophilia, we use, if she has a fibrotic uterus, to try to improve the vascularization of the uterus, or if she has some problem, but only we give them usually for 10 to 12 days. Okay, no more.
Mm-hmm. Fantastic. Thank you again for clarifying this one for us as well. And there will be a last question for our most common questions asked, and we will go to your questions. So here's this one. How can we try to prevent a miscarriage after an IVF?
Can we try to prevent a miscarriage? Okay. So unfortunately, we cannot interfere on the age of the woman. Okay. So, but we have several tools to try to decrease the risk or prevent any possible miscarriage. Okay. For example, a healthy lifestyle. Okay, this for sure. A healthy lifestyle: do not smoke, no drinking alcohol, or stay away of toxics. Okay. Also, if you have any endocrinopathy or problems such as diabetes, hypothyroidism, okay, this should be well controlled. Okay, it has not been demonstrated that if the diabetes or the thyroid problems is well controlled, the risk of miscarriage is high. No, the risk is exactly the same. Okay. Then to check the uterus, we can perform this. Usually we do on the first consultation. Okay, we perform a 3D ultrasound scan. Okay, to check the endometrial cavity, and also we can perform an hysterosalpingography to check the endometrial cavity. And then after, if we suspect of an adenomyosis or Mullerian malformation, we can perform an MRI. Okay. And if we suspect of endometritis, which is a chronic inflammation of the endometrium, we can perform an hysteroscopy. And then after, if we think that this patient has endometritis, we can treat. Okay. Then if we suspect that the patient can have any genetic problem, we perform a karyotype. Here in our clinic, we perform the karyotype in which is the I don't know if they know, the karyotype is the test of our chromosomes. Okay, this is the test that we use to find if the person is normal or has any problem. Okay. And usually in our clinic, we perform in every patient the first consultation, okay, because it's cost effective. It's not expensive, and if there is any problem, its implication will be very, very, very high. Okay. Then, if we suspect a thrombophilia problem, or after a second miscarriage, probably we will do a blood test to rule out any thrombophilia. Okay, but after first IVF, after first miscarriage, usually we don't perform. Okay, and because after a miscarriage, we will do the embryo hysteroscopy to check what is the cause of miscarriage. Is it genetic or is uterine? Okay, and then of course the PGT-A if it's needed in each case, we individualize our patient, and we will think which will benefit from the PGT-A, and that's all.
Perfect. Thank you so much for answering all the questions that we usually receive from the patients. And now it is definitely the time for your questions, and we have actually quite a lot of those already. So let me go straight to the first one. What do you think about PGT-A in general, right?
What I think, I think is a very effective tool. Okay, but I think that the future is the non-invasive biopsy. Okay, and as I told you before, depending of each situation, depending of the patient. Okay, if a patient has any chromosomal disorder, it's mandatory to perform it to decrease the miscarriage rate and to have a healthy baby, because our objective is not to okay, I want to give them a pregnancy. No, we want healthy babies at home. So I think it's a very effective tool. But here I think that with the increase of the PGT, people are crazy about that, and they are performing PGTs in all the cycles, no matter the patient. So we need to come back again and say, okay, this patient this patient will benefit from that. Will she have embryos to be biopsied? Will she benefit? The biopsy will not harm her embryo. So I think we need to personalize each treatment, no matter that the techniques are developing and are very, very promising. But I think that we need to come back just one step and say, okay, let's focus on that. It's good or it's not good for this patient.
Perfect. Thank you for commenting on that. Okay. And now let me go to the next question for you. Do you think artificial intelligence is a helpful tool for PGT?
Wow, that's a difficult question, Harold. Okay, I don't think that artificial intelligence, because depending on each situation, okay, from the moment being, I cannot imagine a robot doing a biopsy, okay, and because I think we are treating embryos, okay, we are not doing, we are not performing a car or doing such a thing, okay, we need to be very, very careful, and I think that we have very talented embryologists and they can perform the biopsy in very, very well conditions. So I don't know if in 10 years these things will be different, but from the moment being, I don't think it would be helpful. Okay, I'm sorry.
Perfect. Thank you so much for your opinion, of course. Thank you. And for your question, definitely interesting one. All right, so now let's me go. It will be a longer question. So here it is. I suffered a still miscarriage in January. Week 5, the embryo stopped to develop and no heartbeat detected. It was a viable pregnancy following in vitro frozen embryo transfer. The conclusion of the pathology of the embryo following was, I am perfectly fine, nothing wrong with my endometrium. What was wrong with the embryo graded 3BB? Why my miscarriage happened?
Okay, Chadi, first of all, I'm sorry for that, okay? Well, as I told you, we need to have a diagnosis, okay? I don't know if they, after when you had a miscarriage, okay, we don't know if this miscarriage, if this embryo, even if it was a 3BB, was a normal or was abnormal, okay? So this is the first thing. We need to check the main cause, okay? If it was an abnormal embryo, we know the cause, okay? It's because the embryo was not good, okay, and it stopped growing. And then if the embryo was normal, we have also the other cause I told you before, okay? Depending on the age, we have uterine causes, okay? In our study, we find that among those embryos which were normal, okay, 100% of that, they had uterine causes of miscarriage, okay? And in our clinic, at least 90% of women, they have adenomyosis, this is a very chronic pathology and can lead to miscarriage, okay? And it's not very, very well known, this pathology, but it affects the uterus and it compromises the pregnancy, okay? So I don't know just by your text what was the cause, but it depends of the age, it depends of if it was a normal or abnormal embryo, it depends of the uterus, it depends also if you have your previous if you had previous pregnancy. It depends a lot. Okay, so I don't know, but probably if you're older than 37 years old, probably would be an abnormal embryo, or even not. Okay, but we need to check. We need to find a diagnosis. This is the most important thing. Here we do not rely on that's bad luck. No, we want to know exactly what happened, why you have a miscarriage. It was because of the embryo, because of uterus, because of your thrombotic risk profile, everything. We need to rule out and to discard everything. Okay.
Perfect. Thank you again for the question and your expertise and also advice. Okay, and remember that you will be able to contact Dr. Alejandra. All you need to do is just click on the link that I have sent you, but I will be able to send it again, and then you can just simply send her a message, and she will definitely get back to you if you would like to get more details. And now let me go to the next question. Patients under 35 with miscarriages and failed transfers with good blastocysts should do PGT?
Okay. Patient under... Thank you, Raquel, for your question. Okay, so in that situation, yes, I will recommend the PGT, okay? Even if she's under 35 years old, sometimes her chromosomal abnormality rate are higher than in people with her age, okay? Yes, to know better the situation, okay? It is a problem of the embryos, or it's a problem of the uterus, so try to find a correct diagnosis, okay? But in that situation, if she had more than one miscarriage, one or more or previous miscarriage, yes, my advice will be just try to do the PGT to try to find the cause, okay? Not try to get no problem, not to find to try to find the cause of they failures, okay? So in that situation, I will recommend the PGT. Yeah.
And perfect. Thank you so much again for your advice. Okay. Now let me go to the next question. Okay, sorry. Here it is. I am 39 years old and my MH was in April 2019 1.5. Any advice on that?
Any advice? Okay. In that situation, for example, if you had not been never in an IVF treatment, no, I will not recommend to do a PGT, because from your AMH, okay, your AMH is low, so I expect to have and low ovarian reserve, okay, not to have a lot of embryos, okay, during the stimulation or during. So in your cases, I'm not sure if to perform the PGT. I won't do it, okay, because it's different. It's very different, the quality and the quantity, okay. In your case, the quality probably is given by your age, okay. We know that you will have probably 30 up to 40% of have an abnormal embryos, okay. But in that case, I cannot guarantee that those embryos will reach stage 5. So probably we'll need to give you the opportunity to get pregnant, to have a transfer, okay. So in that situation, by entrance, we won't do the PGT. Yeah.
Thank you. And actually, we have a question from the very same patient. Okay, so if you could look in the previous session, I was told that with my MH 1.5, it is strange that I only got 2 viable embryos graded AB and BB and not more. How can you explain that?
Okay, the first thing, 1.5, okay, is one, because sometimes it's different, the units, okay. If it's 1.5 picomoles, okay, this is a low reserve, okay. If it is 1.5 nanograms, okay, it's a good reserve. So with 1.5 and having 2 embryos, I think probably, we don't know if it's day 3 or day 5, this is what we expect, okay. But I insist, the quality doesn't mean quantity, okay. The quality is given by the age, okay. We always prefer low quantity in a patient being less than 35 years old, that a lot of embryos, a lot of embryos from a patient older than 40 years old, and that's sure, okay. So AB and BB, these are good quality embryos, okay, and that's all. I mean, probably with those embryos, your chances of being pregnant, they are good, okay, depending on your age.
All right, thank you again. And actually, there are like 3 other parts of the question from the very same patient. So if you could take a look at those. I heard that before miscarriage can lead to live birth with the next pregnancy.
I heard that. Sorry, that the miscarriage can lead to a live birth. Okay, this is a topic, okay, that they say after a DNC, the chances of having a pregnancy, they are increased. No. Here in our clinic, we said, when you have a DNC, it's worse, okay? It's when you have a miscarriage treated by or DNC or by oral pills, oral or vaginal pills, this harms the uterus, okay? So this is an very old topic, but no. Here in our clinic, or now what we are finding in a lot of clinical trials, is that after a miscarriage, the risk of uterus damaging is high. So that's not true. I'm sorry, Heidi, but that's not true.
All right, thank you for your opinion as well, of course, on that. And as I mentioned, there is another question here. Okay, why clinics would not perform a PGT on a single embryo? What are the risks to the embryo if this biopsy happens?
I don't know why some clinics they want more than one embryo, because from my point of view, I mean, if a patient only has one embryo, probably we need to do the biopsy of the single embryo. I mean, if the patient has only one embryo, sometimes what we do, or sometimes what the other clinics do, is that because of costs, okay, they prefer to accumulate embryos, and then we do all the biopsy in all of them, because it will be cheaper for the patient. But if the patient only has one embryo, this embryo will be biopsied without any problem, okay? What are the risks of the embryo if the biopsy happens? It depends on the quality of the embryo, and it depends also of the technique, Okay, it depends on the embryology, it depends on the quality of the embryo, it depends on the age of the bone, because it's not the same a blastocyst, a good quality blastocyst being 40 years old than being 20 years old. So the quality is not the same. Okay, even it's in an euploid embryo. Okay.
Perfect. Again, thank you so much for your question.
Thank you.
There is actually another one coming. Okay, what if both women and men are genetically healthy and no common mutations are diagnosed? Does it still make sense to make a PGT on the embryo?
Depending on the situation, if it's no clinical risk, if it's not, if the couple has not any chromosomal disorders, okay, we need to personalize the case. We need to find out if it's good in that case to perform the PGT. If we want to rule out any chromosomal disorders on the embryo, we need to do the PGT. If we are sure that probably this is not the cause of the implantation failure or the previous miscarriage, probably we won't do it. Or if we think that we are facing an uterine problem, we will treat this uterine problem before doing a PGT. Okay, so it depends on each situation. And the PGT is nothing. I think that your question is that if both women and men are okay genetically, why the embryo is abnormal? Okay, it's because when the oocyte, okay, the oocyte is on, when it's starting the meiosis, when it starts dividing, okay, if the oocyte is old, okay, there are a lot of mutation of this oocyte, okay. The division of the cells are they have a lot of mistakes, so that's it results with an abnormal oocyte, okay. And if the oocyte the spermatozoid fertilize the oocyte, they will give an abnormal embryo, even if you are genetically perfect. Your oocyte is not genetically okay. I think that was the question. Sorry.
All right, perfect. Thank you again for explaining this to us. And now we have a quite interesting question as well. Would you not recommend PGT-A with egg donor if the patient is concerned about loss of reproductive time and doesn't want to waste time on a pregnancy that may result in miscarriage?
Okay, that's not true, because when we guarantee embryos, we here we have the policy that if we select a donor, this donor should be in the best. She needs to guarantee that she will provide very good embryos, because if she doesn't provide very good embryos, we don't select this donor, we discard this donor. So we guarantee that those embryo probably those embryo will end in a pregnancy. Okay, sometimes it's difficult, because sometimes if it ends in a miscarriage, probably it's because of the uterus or because of another cause. Okay, but if the woman doesn't want to waste time, this is not wasting time. Okay, because the risk of miscarriage due to chromosomal abnormalities in a donor, they are very, very, very low, less than 10%. Okay, and 10% is the risk of spontaneous of general population, spontaneous conception. Okay, so this is not always a wasting time. I think that's all.
And thank you again commenting on this particular question. And now let me go straight to the next one. How do we know if a clinic has a good embryologist to perform PGT-A without causing damage?
How do we know? Well, usually the clinic, the reproductive clinic, guarantees a very good laboratory. Okay, those who work with the best technology, with the best incubators, okay, that we know. So I don't know, and I don't know which lab doesn't guarantee that, because I think that if we create, or if we create a clinic, its laboratory will be very good. Okay, so you can ask because also there is some certificates, okay, certificates of excellences, and so you can ask the lab, you can ask also the which training programs has the embryologist. So, but usually they are very, very good and very talented, because fortunately there are a lot of embryologists, and they are improving a lot their technique, because they are working a lot, and we have a lot of cycles, and each cycle they give them the better. Okay, so here the bigger is the clinic, and the bigger, I think that the bigger is the clinic, and that the lab is better.
All right. Thank you so much for, again, another comment and your advice. And actually, we have a follow-up question that you had answered. So let me show you this one. It's about the wasting reproductive time that we had the question before the previous one. Okay, so it's like, I'm aware that there is a low likelihood of a bad embryo, but when a woman is approaching 50 and will not be allowed to receive frozen embryo transfer in some countries, a miscarriage could mean a loss of several months depending on the cause, damage due to the procedure to clear out the miscarriage. Couldn't it? In addition, I estimate I'm losing about a year now due to COVID-19 because I have to go out of the country and there are heavy travel restrictions. I wouldn't probably want to risk contracting it before a vaccine by traveling. Thank you for that question.
Okay, so in that situation, I agree with my statement. There is no recommendation of doing the PGT. Okay, we can select a donor, okay, compatible with you and compatible with your partner, okay, and also it can be a proven donor. It can be a donor that has given live births, okay. And in that case, because the risk of miscarriage it's very, very, very low, okay. Usually, if you have a miscarriage at your age with a donor, usually it will be because of a uterine problem or another problem, okay. But if this will be a reason to increase your anxiety, we can perform, okay. It's not recommended, but I mean, if you will feel better with that, we can do it. But probably your time until pregnancy will be the same as if we don't do the PGT, and this will increase the cost. But if this will benefit your mental health or everything, we can perform without any doubt. Okay?
Perfect. Thank you so much. We do have a follow-up question to this one. So let me show you that one. PGT-A is the only way to truly predict gender of the baby, isn't it? Someone just wants family balancing. It's not illegal here because no strong preference overall. Any comment on this?
Okay, yeah, it's forbidden, the gender selection. Okay, so when the genetist knows the sex, okay, so sorry, when the embryologist do the biopsy, okay, then no one knows the gender of the baby, only knows the genetist. Okay, once the woman is pregnant, we can ask for the sex. Okay. The PGT is the only way to truly predict the gender. Yes, but we know the doctor and know the embryologist knows the sex, so it's exactly the same. We are not playing with gender selection. Okay, so here in Spain is forbidden. I think that in the United States is allowed. Okay, but I don't. From my point of view, I don't agree. So only when there is X-linked disease or some monogenic disease that needs we need to perform a gender selection. Of course, we will analyze and we will transfer the selected sex. Okay, but if it's only to rule out chromosomal disease, we don't know the sex.
And thank you again for clarifying this. Yes, I mean, different laws in different countries for sure. We definitely know in Spain, it's just simply not possible, right? Okay. Okay. There is another short one here. Opinion about rebiopsy of the embryos.
Definitely no. Okay. Always it depends. It depends on the situation and it depends of the age of the woman. Okay. Why? Because an embryo who has been an embryo coming from an old woman. Okay. When I say old, I'm saying in reproductive terms. Okay. I don't want people to say, "Oh my God, I'm old." No. But when we biopsy embryos coming from older women, okay, these embryos probably they are not in a very good quality, and even if we biopsy embryo, we froze, and then we don't have a genetic diagnosis, and we need to rebiopsy, it kills the embryo. Okay, so it's better not to touch those embryo. Sometimes it's difficult. Sometimes we need to do it, but we know that in advance that probably this embryo, its implantation rate will be decreased a lot. So in my opinion, it's better to get other embryos or do another cycle that rebiopsy those embryos.
All right, perfect. Thank you so much again for this. And this is another question for you. How do you treat immunological endometrium issues? What does it mean exactly, and how does it affect the in vitro pregnancy? How long does treatment last before going for in vitro?
Okay, this is very controversial, okay? Because now a lot of people, they have a lot of randomized control trials talking about the immunity status, okay, the natural killers, the cytokines, everything, okay? But it has not been demonstrated that the immunotherapy improves the outcome, okay? So the treatment with prednisone, the testing for natural killers, these kind of things is not recommended. Okay, no society recommends these tests. Okay, even if they had a lot of published articles saying that the treatment with prednisone has been it's good after a miscarriage or it's good to improve implantation. Sometimes that's not true. Okay, it's not recommended. Okay, sometimes it's true that we use prednisone. Okay, because she has already any immunitary disease. Okay, she has a lot of people have endometriosis, okay, which affects her intestine, okay, her bladder, and they have several endocrinopathies. So okay, and in that cases we can give them prednisone to try to balance her immunitary status. Okay, but it's not recommended. It's not recommended to test for thyroid antibodies, natural killers, the KIRs, the HLA. So that's not recommended. And I think.
Yeah, sorry. Yes, I am, of course, here. Thank you again for this question, as well as your advice, your opinion on it. And this will be a longer question. Again, here it is. I have 8 years of healthy blastocysts. I have had 2 biochemists. I have had a lot of hysteroscopy, a laparoscopy, and I am even treated immunology. My doctor thinks that I have something but does not know what it is. I have been tested Ira, Alice, and Emma. I have one last embryo left. This time we will do a natural cycle. Say that I achieved a natural pregnancy after a negative transfer and lost it. Another biochemist, I'm scared. I am 35 years old and have endometriosis and have had a tube removed.
Okay. So, Begoña, you are a patient, a prototype patient of our clinic, okay? And I will explain you why. Okay, so first of all, biochemical pregnancy. Okay, biochemical pregnancy is that I have a positive urine test or positive blood hormone test. Okay, and then once we do the scan, we cannot see anything, or the embryo has not implanted. Biochemical pregnancy, usually it's due to a tubal factor, uterine factor, okay, transfer factor, okay, because sometimes the transfer technique is very, very, very important. Okay, a transfer with pain or a transfer with bleeding is a negative or a biochemical pregnancy. Okay, and also it can be an embryo factor. Okay, but this is controversial. So after a biochemical, we need to think what happened. Okay, probably it's because of the uterine factor. And if you have endometriosis, I read that you have endometriosis, okay, we need to focus on your uterus. Why? Because you are 35 years old, you are young, so I expect to have very good embryos, okay? Even if you have endometriosis, okay, the endometriosis decrease the quality of the embryos, okay? But I'm sure that you still have euploid embryos, okay? Then you have the hysteroscopy, laparoscopy, and even treat with immunology, okay? The hysteroscopy and laparoscopy is very important, and it has to be done by a reproductive surgeon. Okay, it's very important because the reproductive surgery wants to restore the functionality. Okay, it's not all okay. I took out the polyp or I see the endometrium. No, it needs to restore the functionality. And how do we know that the function has returned? If you get pregnant. Okay, in that situation, the hysteroscopy and laparoscopy, I don't know if they was done by a reproductive surgeon or what was the findings, okay? The immunology, I do not recommend to treat the immunology because here it has not been demonstrated that it improves the outcome, okay? I have been tested by Era, Alice, and Emma, okay? Here is very controversial, okay, the ERA test. Here in the clinic, we don't believe that this will change our management, okay, because the endometrium is different each month, okay. So one month you can be receptive, and then next month no, okay. But normally this will not get much information, okay. Then and Emma, it's very important also that we need to rule out endometritis, okay. So it's important that we do a diagnostic hysteroscopy and we check the endometrium, or even we took a biopsy to check if you have endometritis, because after 2 biochemical loss and 3 biochemical loss, something happens, I'm sure, and probably this is a uterine cause, and we need to perform some tests. We need to perform, for example, an MRI to determine what is the cause, okay, to check your fallopian tubes as well, okay, and to identify the cause, because I'm sure sometimes even 1 biochemical loss could be because of the embryo, probably, okay, I'm not sure, but I'm sure that 3 biochemical pregnancy there is a lot more than the embryo, okay. And even if you had endometriosis, we need to focus on the fallopian tubes, we need to focus on the subendometrium, okay, and we need to focus on the walls of the uterus, okay, because a biochemical pregnancy means that the endometrium is well prepared, okay, the endometrium, because the embryo has given a positive beta, okay, but then after that you lose that. So we need to find out what is. So I'm sure that in your case, you have a uterine factor.
And thank you so much for sharing your story as well, and of course your experience.
I wish you all good luck, Begoña.
Yes,
you will get it.
Fingers crossed. Okay, and now we have another actually question here, and have a look. I'm in the beginning of the process, so in the situation of diagnosis of adenomyosis with Seneca uterus and perform 6 hysteroscopies, what would be your advice to avoid miscarriages or bad results on the embryo, or even to improve this diagnosis? And follow-up question is PGT-A a solution?
Okay, Carlina. Sorry, can you tell me your age?
Yes, if you could type that in so we can
Okay, well,
make sure. Just
41. Okay, so Carlina,
thank you.
definitely you have a uterine cause. Okay, the uterine adhesions, the Seneca, are cause of usually implantation failure and also miscarriage. Okay, this is one of the most difficult things to treat. Okay, because there is a problem after your 6th hysteroscopy. There is a problem of the endometrium, the problem of the subendometrium. Okay, here in our clinic, we treat with doing hysteroscopy, and then we put a balloon inside the uterus to try to avoid again the Seneca. Okay, after we perform, we give you some drugs to try to increase the endometrial thickness. Okay, but it's difficult if because sometimes this is called the uterine disease. Sometimes is called Asherman syndrome if it's caused by DNC and by previous miscarriage. Okay, if your endometrium, if you only have the problem of adhesions, okay, we do the surgery, put a balloon, and then we put a balloon on at least 6 weeks to try to not to prevent the Seneca. Okay, but if the endometrium is not growing well, we have other tools, but this is very difficult. Okay, but I'm sure that you will go well. Okay, but it's difficult, and it's PGT-A solution. Okay, depending of your age, depending of your ovarian reserve. Okay, if your reserve is low, in my opinion, I probably will not do the PGT. If you had previous miscarriage and if your ovarian reserve is very good, that probably will have good enough embryos. My advice will be to do the PGT-A, but it depends on the result of the cycle in your previous story. Okay, so that's all. Okay, and the adenomyosis also is a problem. Okay, so it's probably is a cause of miscarriage, not even the PGT. So even if you have an euploid embryo, and then if we put that euploid embryo in a patient with adenomyosis and with Seneca uterus, even if it's a normal embryo, it will not implant, or it will end in a miscarriage because of the uterus. So it needs to be treated.
Perfect. Thank you so much again for sharing your story as well as your advice on that. And we have a very short question right here coming up here. Can you PGT-A an already frozen embryo?
Yeah, it's possible to do it. Although this embryo will lose quality, okay, because it's a rebiopsied embryo. But yes, for sure, we can, as a technique, we can perform it. As it's recommended, it's not very recommended, but we can perform it. It's only the last case or the last chance we can perform it.
Perfect. Thank you so much for advising on this as well. And now we have another quick question right here. Hi, I'm nearly 50 years old, never been pregnant. I will be doing egg donation IVF. I am the main income earner. What do I need to do to prepare?
Okay, so Michelle, thank you for the question. Okay, here in that case, I mean, without knowing you, without knowing your situation, without knowing your ovaries, probably our recommendation will be going through an egg donation, okay, because of the age. Because usually women having 50 years old, we cannot go through their own eggs because they will be in a very poor quality, or even we need to have at least 100 oocytes to try to get a normal embryo, which is very cost effective. It's not cost effective. Okay, so this will be our advice. Sure. Okay, depending on the situation. I mean, only by knowing your age. Okay, to prepare for that, to have a healthy lifestyle. Okay, no smoking, no alcohol, decrease the caffeine intake. Okay, and also if you have any pathology, if you have a high weight, you have to lose weight. If you have diabetes, it needs to be well controlled, the same as the thyroid. Okay, and then just to come to a fertility clinic and get advice.
And thank you. Actually, we have a follow-up question from
Okay.
same patient right here. If I have a mild yeast infection, how long should I wait before IVF treatment? I'm nearly 50 and doing egg donation.
My yeast, what is yeast?
I actually am not sure, but if you could follow up and just let us know what you mean exactly, so we can help you out.
Okay. I know this
Okay.
is like mycosis. Okay, so it depends on which infection.
Yes.
If it's a candida, or if it's only bacteriosis or vaginosis, we need to do a culture of the vagina culture. Okay, but it depends of the type of mycosis. Okay. Probably in 2 weeks it will be enough. Okay, and it's very important that you take probiotics. Okay, because it will be restored your vaginal flora. Okay, but you need to be sure that you are clear from this infection. But it's better if you are without infection after the IVF treatment. Okay, although it has not been demonstrated that the inoculation of mycosis inside the vagina after the oocyte pickup, but it's better if you are in the best healthy stage until before the IVF treatment.
All right. Thank you so much for getting back to us on that as well. And we will be slowly finishing. We have only like 2 questions left, but let's go to the next one. So this is like your final call. If you have any questions, just go ahead and type them in. And now let's go to the short one. So can you comment on that? But low quantity is related to low quality?
Not at all. Okay. The quality is related to the age, and the quantity is only what do we have? What do we have in our body at that time? Okay, a woman being less than 35 years old who has a low quantity, okay, she has exactly the same chance of pregnancy that a woman with her own age. Okay, her age, but low quality is due to the age. Okay, we prefer for sure a woman being less than 35 years old with low quality than a woman older than 40 years old with a lot of oocyte. Okay, because this quantity, I mean, she will have a lot of oocyte, but probably half of them will be in a very, very poor quality. Okay, so it's not related. Low quantity is not related to low quality. Okay, the quality is marked by the age.
Okay, perfect. Thank you so much again for that. And as I've mentioned, it looks like it is our last question for today. So I'll show you that one. I am 39 with AMH of 5.7. I have had 1 natural pregnancy with a miscarriage at 6 weeks. Would you recommend PGT-A?
Okay, in that case, it's very important to have a general checkup with you. Okay, it's important to check the uterus, it's important to check your fallopian tubes. In that situation, if we don't find anything that suspect us for a miscarriage, yeah, probably we'll perform a a PGT. Okay, if we don't know if your embryo was normal or abnormal, probably we will do a PGT. But depending also if your ovarian reserve, if your uterus, okay, if you don't have a healthy uterus, probably we'll know that the cause of miscarriage was that. Okay, so probably we'll say, okay, let's try a cycle with us, and then we will perform an embryo transfer. It depends of each situation. Depends also if on your uterus, the fallopian tubes, okay, your healthy stages, okay. So we'll perform several tests on you, okay, to check what is the cause of the uterus, okay. Even if we don't know, we are sure that not sure, but even that we know that probably the cause of the miscarriage was the embryo, but we need to rule out the other pathologies. So in that case, if we need to check you before, we cannot advise you to go through a PGT-A without seeing you before. Okay, so depending, if we see that your uterus is perfect, that you don't have any problem on the fallopian tubes, that your blood test, your karyotype, it's perfect, probably we won't recommend the PGT. We would recommend, sorry, there was a mistake.
All right. Perfect. Thank you so much. And I believe that was our last question. But if anyone has any other questions, remember you will be able to click on that site. And when you do, you will be actually able to connect with the Juana Crespo team, but also Dr. Alejandra. And I'm sure she will be happy to get back to you. So if you need any additional comments or need any other recommendations, just go ahead and click on that website, and I'm sure they will get back to you very, very soon. And of course, let me remind you that again, you will have a chance to rewatch this patient meeting as well. It will be available on our website with the exact same link as well. So stay tuned. It will be uploaded very, very soon. We are definitely working on that. And well, I would like to thank you, Dr. Alejandra, for joining our
You're
initiative
welcome.
together. It is a pleasure to have you. I would have never guessed this is your first webinar. So
thank you so much.
happy to have you here with us. And well, is there anything else you would like to add?
Thank you so much. I would like to reassure the patients. Okay, I know that facing a pregnancy loss is very difficult. It's it's very sad. Okay, but you need to still go ahead, because we have tools. We have several tools like the PGT-A, that the tools that I commented before, that we can improve the outcome. So don't be sad, and let's try them, because probably you would get a healthy baby at home soon. Okay.
Perfect. Thank you for that. And actually, let me show you that I'm not the only one who is thankful.
Thank you.
You're
You're welcome, Carolina.
Was very helpful. So thank you for joining us. It was quite an evening. We had two events. So I know some of you already had a chance to just join the actual first event, and now we are at the second one. But I would like to also add, this is not the end. Next week, we will have plenty more to come. So stay tuned, and you can definitely have a chance to get to know some other top experts, of course. So,
Bye.
so thank you so much for joining.
Bye.
And last but not least, sorry, the time is doing it to me. Sorry about that. But I just wanted to add that all those events are available on our website, myivfanswers.com. I have already sent you the link to this event as well, so you can follow us on YouTube, Facebook, or Instagram. You will be updated about all the events that are coming next week, and there will be like 10 of them coming. So I would love to see you there starting Monday. Have a lovely weekend as well. Stay safe. And again, thank you, Dr. Alejandra, and thank
You're
you
welcome.
all for joining us. Thanks so
Thank
much.
you.
Bye.
Thank you. Have a lovely weekend. Bye all.
Bye.